Good afternoon. Very warm welcome to you, the audience of our panel discussion, and to our distinguished panel speakers. To our panel discussion, Universal Health Coverage, New Choices for Best Practice within the World Health Summit 2020. My name is Bernadette Klapper. I'm Senior Vice President at the Robert Bosch Stiftung in Stuttgart. I'm very honored to chair this panel discussion. The reason that brings me here as a foundation representative and not as a scientist is the cooperation between the Robert Bosch Foundation and the World Health Summit, which started in September. The Robert Bosch Foundation brings in all the activities from its initiative Restart, Reforms for Our Future Healthcare. We aim to secure health coverage and good quality of care despite the huge challenges ahead of us. And we all experience with the COVID-19 pandemics a huge challenge already in our days as of today. The interest in healthcare reforms brings us together with the World Health Summit. Our cooperation is about to strive for health for all people. Being here on this panel is a milestone in our endeavor. I do want to mention further partners also in this cooperation. It is the Berlin-Brandenburgische Academy of Science and the Hertie School in Berlin. So the title of our panel today is Universal Health Coverage, New Choices for Best Practices. What is it about? What brings us together? COVID-19 is a magnifying lens on strengths and weaknesses of healthcare systems. We painfully learn once more that we cannot be healthy on our own. Our health is not only dependent on effective medicine, but essentially on overall healthcare orientation in our healthcare structures, with public health, health promotion, and prevention building the basic fundament. Sustainable healthcare structures will also reflect and adapt to the regional needs in order to balance and address appropriately geographical and social differences. They have to rely on evidence about the given regional and population needs, on monitoring health care status, their progress and successful activities, and they highly depend on social solidarity, on a robust connection to civil society. A good level of health literacy of both decision makers and population will be the power fuel of steady improvement. Our speakers will now present their different perspectives on this topic. I am very happy to present our first speaker, Dr. Lakshmi Balaji. Dr. Balaji is senior advisor and is heading the Health System Strengthening Unit at UNICEF headquarters in New York. He is a medical doctor with an advanced degree in public health and a doctorate in epidemiology. He has been with UNICEF for over 30 years and has worked in both country, regional and headquarter offices. Throughout all these long years, Dr. Balaji was responsible for many important tasks and programs. For example, he was chief of strategic planning from 2004 to 2014 and was deputy representative managing UNICEF-supported programs in Afghanistan for 3 years. Also among his responsibilities, Dr. Balaji manages EQUIST, a system for equity-based planning and prioritization in primary healthcare systems for delivery of public health services at national and subnational levels. He also coordinates UNICEF support programs at country level on various aspects of primary healthcare and health system, strengthening for achieving SDG 3. I'm very happy that he will give us an introduction on the history of universal health coverage and will relate it to primary care. Dr. Balaji, the floor is yours.
Thank you, Dr. Bernadette. Let me go. Thank you for that introduction, and thank you, colleagues. Good afternoon, good morning, good evening, depending on where you're joining this meeting from. As Dr. Bernadette mentioned, I will give a little brief history of the universal coverage, health coverage. As you know, Alma Ata Declaration in 1978 put health as a fundamental human right, and it primarily was aimed at addressing inequality that is necessary for economic and social development and peace, and that people have a right and duty to participate in their health. The Alma Ata Declaration also defined primary health care, and several goals were set. 40 years later, exactly on 25th of October 2018, 2 years from before on this date, Astana Declaration was committed by a number of governments, and UNICEF and WHO were together with the government of Kazakhstan, the main host to this conference. The conference was organized, and the declaration made bold political choices for health across all sectors to build sustainable primary health care and empower individuals and communities and align the stakeholder support to help national and subnational policies and strategies and plans to achieve primary health care. Last year, the UN General Assembly session on universal health coverage particularly noted the interconnectedness of the Sustainable Development Goal 3 with all the other Sustainable Development Goals, meaning to achieve health, you have to achieve many other Sustainable Development Goals. The UN General Assembly Declaration on Universal Health Coverage also focused on the need to focus on the poor, the most vulnerable, and those with disabilities. The UHC effort has to be people-centered, and quality assured health services through the full life course of an individual is necessary. Community-based health with engagement of civil society organizations and primary and private sector was felt as a necessary ingredient. Primary health care and health system strengthening was noted as the cornerstone to achieve universal health coverage, with the emphasis on resilience, which we now realize, particularly during COVID times, as being more critical. The approach to UHC and health well-being is basically, as you see in this present graph, the center, these health and well-being has to have a multi-sectoral policy and action, whether it is food systems, child protection systems, education systems, WASH, or the social protection, the interconnectedness with the other SDGs. It has to have the strong, empowered people and communities with community engagement and systems with social accountability. The primary health care itself needs to be integrated across many sectors: health, nutrition, HIV, and ECD services near and where people live and work. To get that, you need to have very strong health system strengthening at national and subnational levels in all of these 7 areas. Supply chain management to get drug and pharmaceuticals closer to people, a good quality of care, data and digital health to inform what happens to the communities and how our systems are functioning, a good governance management and partnership across multiple sectors and multiple stakeholders. Private sector, we now know, is an essential partner in delivering health services, and national and subnational financing with a strong health force our health workforce are necessary ingredients to see that primary health care. 12 agencies challenged by the governments of Germany, Norway, and Ghana developed a global action plan for healthy lives and well-being. The idea is to provide collaboration and support amongst the 12 UN agencies and as well as the 3 global funds to support countries that is more purposeful, systematic, transparent, and accountable. And it leverages the agency's collective strengths. It is also to better align their ways of working to reduce inefficiencies and provide more streamlined support and harmonized support to countries. And it is essentially puts this country at the center, and it is the country's priorities which inform the whole collaboration and support and promote cross-sectoral issues such as gender equality and attention to the poor, the marginalized, and the most vulnerable. The idea is to engage with the countries, align and harmonize their operational and financial strategies, accelerate by supporting the countries around accelerating themes and on advancing gender equality, and be accountable by reviewing progress and learning jointly. Within the primary health care implementation, the idea is to provide intensified primary health care implementation through enhanced visibility and advocacy of the primary health care, increased technical and financial support, good monitoring and reporting of progress, so using the primary health care monitoring and evaluation framework or the primary health care performance improvement initiative that many countries are doing, improving the access to best practices and knowledge on PHC, and improving the alignment of partner organizations around a single primary health care support roadmap. And that way, there is decreased transaction costs and increased efficiency of investment on PHC by partner organizations. The GAP itself has several accelerators. These are the 7 accelerators, and I will very briefly touch on how COVID is challenging all of us to make the GAP accelerator function even better. Primary health care, it is new ways of delivering essential health services and overcome the disruptions in health services to the women, children, adolescents, and all of the people is something that is being challenged. Sustainable financing. Countries are finding that they need sustainable financing not only to respond to COVID, but also to build back better systems together with the community and the civil societies. The new ways of delivering services are emerging. For example, how to cut down the number of times people need to come to a center by effectively reaching people through digital and other innovative ways of delivering primary health care, and get them to a center where social distancing and quality of services through infection prevention and control is going on extremely well, so that people are safe and they can access services in a very safe and better way. The data and digital health interventions are improving, and real-time information is providing support to communities and to healthcare workers in a way which is not happened before, and these hopefully will remain well beyond the COVID times, so that the systems are strengthened and can function even better. A lot of research and development and innovative ways of accessing communities are being tried out, and these are indeed the right GAP accelerators, which are now taking a new way of implementing, particularly during the COVID times. Many countries are looking at how to overcome the disrupted services. It is very clearly emerging that although in the COVID time, because of lockdown or other measures, all activities, including essential public health services at communities to a certain extent were disrupted, and hospital services also were oriented towards delivering services to those affected by COVID and very serious and emergency conditions. It is now these community-based services are being revived faster, and it is hoped that hospital services are also catching up, and with improved prevention and control measures in place, they will end up delivering services in a higher quality and thereby meeting the objectives that was set out through the primary health care and the universal health coverage agenda. Thank you, Dr. Bernadette, and I will stop here and hope we will have questions later during the session.
Thank you very much, Dr. Badaji, for pointing out the really crucial importance of primary health care in the universal health coverage scheme. Also for saying and reminding us that SDG 3 is not only SDG 3, but it has to be achieved by also working on all the other sustainable development goals. And also how to accelerate our systems in getting there. This was very, very appreciated. Thank you very much so far. I would go ahead over now to our second speaker. This is Professor Mujahid Shaikh. Mujahid is Professor of Health Governance at the Hertie School in Berlin, and I'm particularly happy to announce him as his chair is funded by the Robert Bosch Foundation within our initiative Restart Reforms for Our Future Healthcare. Professor Shaikh is Professor of Health Governance at the Hertie School. His research concentrates broadly on the field of health economics and management with a focus on health expenditures, hospitals, and efficiency and competition, and health insurance. Mujahid holds a doctorate in economics from Frankfurt School of Finance and Management and a master in international health management from Imperial College in London. He has published in top field journals and has won several international awards for his research papers. However, it is his passion for bridging the divide between policy and research by informing governance discourse through rigorous scientific evidence which defines his spirit as a health economist. And I'm very happy that he will talk now about the governance side of our endeavor. Mujahid, please go ahead.
Thank you very much, Bernadette, for this very nice introduction. It is a pleasure to be on this panel with such distinguished speakers. And I'm glad that the World Health Summit decided to host a session, and the Robert Bosch Foundation also jointly with the World Health Summit decided to have a session on universal health coverage and governance. I am wondering if you can see my slides properly because so you can read everything well, right? Great. Then let's start off. Dr. Balaji already in the beginning spoke a bit about the history of universal health coverage and how old really is this concept of universal health coverage. A lot of us will remember it because of Otto von Bismarck, for instance, dating back to that time in 1883, when the social insurance for employees was initiated by him. And then it took off in a lot of other countries like Sweden, Denmark, with the English NHS in 1948 and so on. Recently, I came across a Financial Times article which basically mentioned that it dates back as far as ancient Egypt. A civilization was supposed to be very, very advanced. In ancient Egypt, doctors usually used to visit the homes of people to treat, especially workers, to treat them for sickness and illness. So it is a really, really old concept. And we do know a lot about universal health coverage now. We've gathered a lot of evidence over the last decades on what UHC is, what we should be doing to improve coverage in across the world in all countries. However, what have we really achieved and how we are performing when it comes to universal health coverage? So this map over here basically shows the UHC achievement index. The darker the green color, it means the better the coverage, and the lighter the color, the lower the coverage. So this is as of 2015, the data from 2015. And you see a lot of the countries, particularly in the African continent, in Asia and South Asia, such as India, Pakistan, and so on, have really low levels of coverage, right? And then I started thinking, why might that be? Could it be related in some way to the governance structures in these countries? And what might it be? And then I looked into how serious countries are about UHC legislation. So as of 2017, this map shows you which countries actually have a UHC legislation officially in place in the statutory laws, for instance. The green countries are the ones which do have a universal health coverage legislation, and the red ones are the countries which do not have the legislation. So it looks very similar to what we saw before in terms of the performance. Countries which do have a legislation in place have better performance in terms of UHC. Countries which do not seem to have lower performance. However, two other interesting things to note over here is that there are some countries, for instance, within the African continent that do have a UHC legislation in place, such as Botswana and Bolivia, but still have very poor UHC coverage. And then there is Peru, for instance, in Latin America, which does not have a UHC legislation in place. But if you go back to the previous figure, you see that it's dark green. It does have high levels of UHC coverage. So what, if anything, is the relationship then between having UHC legislation or governance embedded within the framework of the country and UHC coverage itself? If you just take the average performance of these countries, so countries with no legislation indicated by the blue bars, and countries which have a UHC legislation with the red bars, you see that countries that do have a UHC legislation in place actually have better performance overall on average. Of course, there are exceptions within these countries as well, but overall, you can say on average, countries which have a UHC legislation do perform better. However, do countries with better governance have UHC legislations in place? To have a legislation, do you have to have better governance? So if anything, what is that relationship? And how do we define governance at all? It has been defined in many different ways. For the purpose of this talk, I will stick to what the World Bank and the World Governance Indicators talk about it. It's basically the traditions and institutions by which authority is exercised. It includes the processes by which governments are selected, monitored, and replaced, the capacity of the government to effectively formulate and implement policies, and the respect of citizens and the state for the institutions that govern economic and social interactions among them. Following this definition, the World Governance Indicators outline 6 main indicators of governance, which is voice and accountability, government effectiveness, political stability and absence of violence, regulatory quality, rule of law, and the control of corruption. Of course, these indicators are not new. The WGI has been, accumulating evidence and data on these indicators for a very long time now. But what does these indicators mean for having a UHC legislation itself? As you can see, on the y-axis, you have the mean index value of each of these indicators. So positive values indicate higher governance, and negative values indicate lower governance or lower achievement on governance indicators. If you look at the countries which have a UHC legislation versus the ones which do not have a legislation, the ones that do have the legislation have high positive indices on all of these indicators, right? They're better with voice and accountability, with political stability, especially government effectiveness is one of the highest governance indicators for the countries which have a legislation in place. The picture is exactly the opposite for countries which do not have the legislation in place. So it seems that governance, after all, is important for simply having the UHC legislation in place. But does that mean if you have a legislation in place, you're automatically going to perform better on on the UHC index? Not necessarily. So to understand that, we look at the correlation between each of these governance indicators and UHC achievement itself. You see, there's a strong positive relationship between voice and accountability and political stability with UHC achievement itself. So higher the voice and accountability index, better your UHC achievement is. The same thing for political stability as well. You look at the other indicators, you will find the same thing. Government effectiveness and regulatory quality. very strongly positively correlated with UHC achievement. In fact, the slope of government effectiveness is much stronger compared to any other indicators. So government effectiveness really matters. You look at rule of law or you look at control of corruption, you will find the same picture again. They're very strongly positively related with UHC achievement. So it seems governance is really crucial to having UHC. Not only is it crucial to having a UHC legislation in place, but it is also crucial to having actual UHC coverage, high coverage. Then if you separate, the regression analysis basically that we did to see what the impact of each of these indicators is on overall UHC achievement, you see government effectiveness clearly stands out. It has a very strong relationship compared to the other indicators, followed by regulatory quality. Yeah. And then if you split the analysis by looking into countries that have a UHC legislation in place versus that do not have a UHC legislation in place, you see that the impact or the relationship of of these governance indicators is much stronger for countries that do not have a UHC legislation. So governance actually matters even more for those countries that do not have a UHC legislation in place. So having a legislation does not mean you're automatically going to have high universal health coverage. What is really important is these indicators of governance, whether you have good governance or not. Yeah, as Dr. Balaji already mentioned, we've had several declarations in the past. We've got the Alma Ata Declaration, we've got the Asana Declaration. Today, when I was watching the news in the morning, I saw that there was a peace treaty signed in Libya to sort of stop ceasefire, to stop firing across the country. And again, that's a declaration that everyone has signed. But then when the citizens were interviewed, we noticed that the citizens were worried and they said, well, we've signed a lot of declarations in the past as well, but nothing really has changed on the ground. So of course, declarations are important, as we saw. Having a UHC legislation is important. It does encourage countries to perform better, but having good governance is equally important. Improving government effectiveness, improving regulatory quality is equally important. Just by stating that we have a UHC legislation does not automatically mean governance structures are in place. Of course, then, since we know all these things, what are really the obstacles then to UHC? I would like to think about it the other way around. What have we achieved over the last couple of months? We've been thinking about COVID as something that has disrupted universal health coverage. It has disrupted healthcare systems and so on. If we flip the coin, COVID has actually made the case for universal health coverage. Countries which thought about not having universal health coverage now think universal health coverage is really important, right? So we've seen countries really making changes at the speed of light recently, whether it is to do with civil participation or digital solutions and public sector innovation. Remember, we cannot achieve what we've achieved in COVID without citizen participation. We have low levels of COVID because citizens have been following advisory given by the government. They have been wearing masks and so on. Of course, there is always a small minority which says that, we're not going to wear masks, so we're not going to follow social distancing, but this is a minority, and this is the flavor of democracy. Yeah, there will be dissent. But by and large, citizen participation has been very important to controlling COVID. Similarly, digital sector innovations and public sector innovations are very important. We've come up with a bunch of tracing apps. We've come up with supermarket tracing in some South Asian countries. These are all innovations that happened at a very short notice. The German government launched the coronavirus hackathon in which citizens participated. There have been several regulatory changes. For instance, pharmaceutical trade has been streamlined. All these regulatory changes have been achieved in a fraction of a time that we wouldn't have imagined before Corona. Several global coalitions have been formed. AstraZeneca's trial is being carried out at the Serum Institute of India. So these coalitions are also increasing. Rapid capacity management has been happening. For instance, in India, the government planned to change 20,000 train compartments to isolation wards for COVID. There have been other changes as well in terms of hospitals. Overnight, you've seen, hospital beds and hospital capacity management being changed. There have been several budgetary changes that have been happening. Governments have pledged more and more money towards handling COVID. So it's not like we cannot make these changes happen. We've seen them happening over the last couple of months. So if there is political will, if we overcome this inertia that we have, and if we focus on good governance, we will definitely achieve universal health coverage as well. All we need is to embed universal health coverage legislation within country frameworks and to make sure governance indicators, not just the general governance indicators that I showed, but also those specifically relating to health are very important, and countries should focus on changing those governance indicators. So that was my short and brief talk, and I will take on questions later on as indicated by the moderator.
Thank you so much, Mujahid. It was really interesting that you brought us the evidence about how it works with the governments and the universal health coverage, and that we got a clearer picture on this, how this is spread across the world. I would like to go now for the next speaker. This is Dr. Marie-Paule Kieny. Dr. Kieny is treasurer at Santé Mondiale 2030. She is currently director of research at INSERM, Institut National de la Santé et de la Recherche Médicale in Paris, and also holds positions as president of the board of directors of Medicines Pool Foundation and DNDI, Drugs for Neglected Diseases initiatives. Dr. Kieny served as the Assistant Director General for Health Systems and Innovation at the World Health Organization. She also directed the World Health Organization Initiative for Vaccine Research from 2001 to 2010. Dr. Kieny held top research positions in the public and private sectors in France, which included Assistant Scientific Director of Transgene SA in the 80s years. And Dr. Kieny received her PhD in microbiology from the University of Montpellier. And she has published over 350 articles and reviews, mainly in the areas of infectious diseases, immunology, vaccinology, and health systems. A very warm welcome to you, Marie-Paule, and we are very much looking forward to your thoughts about inclusion and integration of healthcare system. Please go ahead.
Very much. So let me share the slides with you. Just 1 second. Okay, so thank you very much. It's a real pleasure to have the opportunity to be with you today and to actually share my experience with on health system strengthening when I was at WHO and beyond, and trying to bring together actually what I've learned in infectious disease and UHC and health systems. So next slide. So first, Santé Mondiale 2030, Santé Mondiale, the think tank who I'm representing here, was created in 2016, and it's discussing mainly areas about global health. So it's an independent think tank. The chair is Jean-François Delfraissy, whom many of you may know. The vice chair is Françoise Barré-Sinoussi, the Nobel Prize. And we try to come and provide advice and comments on global health support also, as well as how to advance with universal health coverage and sustainable development goals. So this is a slide that I was using when I was at WHO. Indeed, we need to take a very integrated view of universal health coverage and of SDG 3 within the overall universal health sustainable development goals framework. And if we achieve UHC, we will have impact on many of the SDG 1, 3, 4, 5, 8, 16. And going the reverse, as was said previously by the colleague of UNICEF, if we do not take attention to these other SDG goals, then we won't achieve universal health coverage. That is the definition that we worked on in 2017, when I was there, which is about all people, but also communities having access to needed health services of sufficient quality, because otherwise would you want to have it, without the risk of being exposed to financial hardship. So what do we see right now? Up, back, back, what I can do back, and show, apologies, it went too quickly. here. So, but what we see, and we see, you know, even more with COVID, is that we have so many competing priorities. So on the extreme right here, you have UHC, which is part of a commitment of the UN member states and WHO member states. And this is a lot about reinforcing and strengthening health system. At the same time, you have all the world of health security who wants to move towards strengthening IHR capacity building, reinforcing resilience to crisis. Now we see with COVID response that we need to see how we will move in recovery post-emergency. This is a picture of a natural disaster, but with COVID it will be the same. How do we get better and resilient system? At the same time, we are we still are living in the world which is inherited from the Millennium Development Goals, which generated all these vertical initiative like the Global Fund, UNITAID, Gavi, the Partnership for Maternal, Newborn and Child Health. So these are all very good, but they are all very vertical. So we have all these multiplicity of priorities. And if you see all those of IHR, recovery, and the MDG goals, all of these are building their programs on the premises that there are existing and strong enough health systems, which is quite often not the case. So how can we best integrate health system strengthening interventions? So these are the recommendations from a recent study that our think tank, Santé Mondiale 2030, had on the Global Fund and its link with health system strengthening. So there was an agreement that HSS is a good indicator of a Global Fund strength and also room for improvement. And the conclusion of the study, which was financed by the AFD, Agence de Développement Française, proposed to strengthen 4 of the key historical principles of the global funds, to reposition the global fund as a financial instrument, to have more respect for the country driven. It is country who must decide what they want to do on their health programs. Have also moving to a logic of funding complementarity to that of all other donors instead of being standalone, and an imperative for more inclusive participation. So I'm going the other direction. So why is this so important? You can see indeed that in order to achieve universal health coverage, for all these goals that we discussed, for resilience, for health security, for universal health coverage, you need to have put in place policy which are pro-poor. And equity policies indeed matters. So this is a slide that sees the impact of the financial crisis in 2008, 2012 in Europe. And you can see here that the countries which had pro-poor and equity policies actually had the lowest impact on access to health. You can see them on the left, and you can see that the poorest quintile actually didn't do worse than the richest quintile. But you can see that in terms of access to care, there was a sharp drop in the countries who did not have, in the second round, in countries who didn't have the right policies, and although these countries in the middle were able to preserve the poorest quintile, more or less, whereas you can see that on the right, these countries who didn't have, were the weakest in terms of pro-poor and equity policies, actually did the worst in terms of preserving, during a crisis, access of the poorest population to healthcare. So, what is my conclusion? I think that, and this is also shared with Santé Mondiale 2030, of course, we think that time has passed from vertical silos, but now we all have to recognize that health security, resilience, universal health coverage, all need strong health systems. And therefore, that investment into strengthening them should be everybody's responsibility. The people working on health security cannot presume that the health post will have electricity and water if they do not contribute to them having electricity and water. It will not happen. Cooperation on equal footing should replace assistance, and truly country-driven intervention should supersede good intention neocolonialism. Thank you very much.
Thank you very much, Dr. Kieni, for bringing us this really precise picture about how important inclusion is and how we still live in silos somehow. Thank you very much. And I would like to go to the next speaker, to Professor Tulula Oni. Tulula Oni is a public health physician scientist and urban epidemiologist, a clinical senior research associate and joint lead of the Global Public Health at the University of Cambridge, MSc I'm always struggling with this word, epidemiology unit, and honorary associate professor in public health at the University of Cape Town. She holds a master's degree in public health at the University of Cape Town and a research doctorate in clinical epidemiology at Imperial College in London. She leads the research initiative for Cities Health and Equity Ridge, and she serves on several advisory boards, including Future Earth and the African Academy of Science Open Research Platform. She is on the editorial board of Lancet Planetary Health, Cities and Health, and the Journal of Urban Health. She's a fellow of the African Academy of Science, past co-chair of the Global Young Academy, and also on the 2015 Next Einstein Forum Fellow, and a 2019 World Economic Forum Young Global Leader. Professor Oni, very welcome, and the floor is yours. Thank you.
Thank you for the kind introduction. It's a pleasure to be here, and it's been really great listening to the other speakers so far. I've noted a few words that I must say that it's been a really nice to hear in discussions around universal health coverage, which I don't think are spoken enough. We've heard resilience mentioned a couple of times, issue of governance, the SDGs and not just the SDG 3, non-vertical, the importance of non-vertical systems, the need for integration and silos, unmet need. This is just music to my ears. So I'm coming at it from, I'm bringing another SDG that hasn't been mentioned so far specifically, around SDG 11, around urbanization, because a lot of my work is primarily focused on the African region, which is one of the fastest urbanizing regions, which brings a lot of advantages, but also a lot of challenges to health and forces us to think long term. So I'll be focused on the systems approaches to UHC, and particularly on prevention. Key messages, so spoiler alert, as the first is the need for integrated care, and I speak about that in the context of epidemiological transition, and even within healthcare systems, we need to think more responsively for UHC, and the need for a new systems-based approaches to both prevention and control. So firstly, we talk about the reason I thought to highlight integrated care firstly was just to highlight the issue of within the context of curative and management of the healthcare sector, the silos of diseases that we have. Whereas actually when we look at how the patterns of diseases are changing globally, so this is a global pattern from the 2018 World Bank report, where we see, you know, the top two are what we traditionally call non-communicable diseases, and it's, you know, the top 10 are largely driven by that approach. But actually, when we break it down and when we look at the different, across the different categories of countries, from low income to low middle income to upper middle income and to high income, we actually do see this similar trend. So it's, you know, contrary to the notion that, oh, we see largely non-communicable diseases in high income countries and see just infections and undernutrition in low income countries, we actually see this transition of the epidemiological transition really across the board. Why does this matter? Well, not only do they coexist, but they interact. So we see here, so this is a study we did in South Africa looking at how infectious and non-communicable diseases coexist, and we found quite a high prevalence of multimorbidity. So from one of the studies we looked at in Cape Town, where we looked at HIV, TB, diabetes, and hypertension, found that really the most common comorbidity with HIV was not TB, as you'd think, and which is how our healthcare systems are structured, but actually hypertension, and those are very siloed, and that and a 20% of 1 in 5 had more than one condition. This was a study across the country, South Africa, where we saw this association between deprivation and multimorbidity. Actually, in this study, it was both association with socioeconomic disadvantage and living in an urban versus a rural area, and having obesity, which in South Africa is quite a highly common risk factor and disease, with 40% of women being categorized as having obesity. So the other reason why it matters, and this is really important, is that we're seeing this increasingly younger ages. On the African continent, the median age is 19, and this is often spoken about as a real dividend and an untapped potential. Well, if we're not protecting the health of the younger population, then we're really missing a trick in terms of the sustainable and long-term development of the continent. And what we saw in this study was that we're seeing multimorbidity of these like hypertension or diabetes coexisting with HIV at increasingly younger ages. So that's really concerning. And just to add a sprinkle of complexity, as I mentioned, with urbanization, so that's a broader context within which health is made or undermined. So what we're seeing in many rapidly urbanizing countries is this pushing of boundaries of human settlements, which is disrupting ecology and increasing the risk of emerging infections. We're seeing overcrowding and dense informal settlements that facilitate transmission of both infectious and non-communicable because of the environment. We're seeing this increased vulnerability to disease from the environment, from inadequate infrastructure, and this exposure in younger people, and an inequitable access to care. So I just wanted to lay on that particular context, because when we're thinking about addressing health or universal health coverage, we have to think about that context. The other reason why it's important in terms of when we look at, apart from them coexisting, is that these diseases interact. And I put this here just to highlight the importance of this life course approach, and to start thinking about prevention and particularly in the younger ages, because we know that obviously your health in at a younger age influences the health of the next generation, particularly, but not exclusively women, which determines future adult health. We also know that the risk factors overlap. So when we start thinking about prevention, so we have this kind of siloed thinking often when we think about, infectious diseases, we think about certain risk factors, non-communicable diseases, not certain risk factors. But actually, if we look at the socio-environmental risk factors across these range of diseases, you see arrows going across from both sides of the middle boxes, to indicate really that issues around the food environment, blood pressure, nutrition, issues around air pollution, and access to safe, supportive built environments are really critical across the board. So I hope I've just laid the scene for why we need the spectrum of interventions. Yes, integrated treatment, and yes, integrated screening, but also really critical to do more with upstream. And so for the second bit of my talk, or the last bit, I'm just talking about the systems for health. So this kind of more systems-based approach and I will focus specifically on prevention. So why this rethink? Well, it's a really important issue to highlight the issue of timelines. So when we're talking about addressing disease and creation of health, often the timelines are short or medium and insufficiently long. So we think about how much it would cost now, and we don't think enough about the inadvertent cost of ill health at the population level. And I just want to highlight here the fallacy, and I think I'm in the choir here, the fact that we can't afford to solely treat ourselves out of any epidemic. So if I illustrate this with the example again of South Africa, where where I was based for a long time, there was a study done there by colleagues that showed that if we look at primary healthcare services for cardiovascular disease alone, so just thinking about the complex diseases of cardiovascular diseases at the primary care level alone, if those guidelines were followed by up to about 80% of what they should be, that would bankrupt the health budget of an upper middle income country. So we really can't purely think about how, really important to increase expenditure on healthcare, because a lot of countries are insufficiently spending. But the fallacy that we can increase enough to catch up and solely focus on treatment is something that we really need to think ourselves out of. So we really can't afford to think in the siloed way. The focus is on acute episodic care. I'm really laboring this point because when I actually was publishing this paper around this a couple of years ago, the first journal that I sent it to, it bounced back from a reviewer, a comment from a peer reviewer said, well, Africa is dealing with a lot of issues right now and can't afford to think long term. Yes. So I mean, it sounds like we're saying something obvious, but there's also, in the ways that we're reacting and thinking about health, there are these biases of now and discounting the future that we really need to set asunder. Because ultimately, we know that 80% at least of factors that influence disease, the risk of disease, lie outside of the healthcare sector. And if we know that, then let's do something about that. So lastly, talk about addressing the systemic drivers, because I think it's critical that universal health coverage, a key part of that is really looking at those structural issues that drive preventable ill health. And so this is a provocation to think about systems for health, which I dabble with, because obviously when we talk about, it really is a health system, but health system, that term, conjures up a healthcare system with the WHO building blocks, etc., which are all very critical. And this is what we think about in terms of the healthcare system, from prevention to treatment right through to palliation, and the different exposures, so whether it's available or affordable, etc., and ultimately wanting to reduce mortality and morbidity. But in the context of what I just mentioned, what if we thought differently about what a health service is and what a health system is? What if we thought about the habitation and human settlements as a critical health system? Because we know these exposures, this is just a selection and not exhaustive, really have a greater impact on those intermediate outcomes than anything within the healthcare system, and fundamentally driving this epidemiological transition. What if we thought about transport as a health system? What would governance for health and universal health coverage look like? What would financing for health look like? What if we thought about water and waste? What if we talk about what we thought about food as an important critical health system? And I'm provocatively using the term that we normally reserve for the healthcare sector, because I think we actually need to go beyond just thinking about the healthcare sector interacting with those spaces. And we actually have to think about those spaces as systems for health, because the accountability for health really does and has to lie in those spaces. And our financing when we think about health creation has to align with what we know. So this was this is my attempt to don't even bother trying to follow it, but I just wanted to show, if we, for example, will say, well, what would a COVID system for health look like in the context of where we are now, in the context of understanding factors that inform that influence transmission, such as overcrowding and those kind of exposure factors, in the context of what we know about the modifiable vulnerability factors, which speak to population health resilience. You can start to see, you know, healthcare service, one of them, but the arrows are, the lines are pointing all sorts of directions. So if we were going to do it differently, and we knew COVID was coming, and we wanted to build a system for health with universal health coverage that was with a population that was suitably not, where we reduce the vulnerability to disease and reduce transmission, we would have to be thinking very differently. And we've seen that very different approach playing out in the context of response to COVID. So I'm really pleased to be able to say a lot of the things that we've time and time again been told is not possible or is challenging because we have to change things slowly. A lot of that has happened pretty much overnight in thinking about responding to COVID. So this is really provocation to start thinking, well, if we wanted to think differently about integrated governance, we have to recognize that those risks are interdependent, and maybe insufficiently also recognize that often those systems are conflicting. So in terms of pulling in opposite directions on the impact on health, and how can we think about integrated governance in that context? So we can come back to that if in the discussion. I just wanted to highlight, because in this image I mentioned resilience here, and proactive and reactive resilience. I just want to mention the point of resilience because I have a little bit of a love-loathe thing with that word sometimes, because obviously really critical, but it's often used and implemented in a reactive way. And I just wanted to highlight that certainly I think if we're thinking in this upstream and integrated way, we have to confront the fact that many of the factors that we're having to be resilient against are preventable and driven by intentional choices, right? They might be unintended consequences, but those intentional choices are driving the states, the systems into increased exposure or vulnerability to disease. So when we talk about increasing resilience, it's really critical that we're, yes, talking about resilience to the current state, but that we're actually talking about shifting the system and making the system more resilient and less vulnerable in this way by addressing those structural, those factors that, that influence the structural choices. My last slide. Just to highlight that some key ingredients and maybe a talking point, and some of this has been spoken about already in taking the systems approach. One, the critical importance of vision and leadership. So we've talked about the SDGs already. We have to be thinking, so this was written in the context of the urban. There has to be, if you talk about the notion of a city, what is the vision for the city? What is the city trying to achieve? So UHC is not just one little thing that's separate if the other interdependent risks are actually conflicting against it. So we have to have this coordinated approach. Obviously requires a lot of intersectoral collaboration, that's been spoken about. Performance indicators, in a lot of the work that I've done looking at integrating health and human settlements, one of the key barriers to aligning the goals are differing performance indicators. And so how do we actually think about that? And relatedly, the accountability for health as part of our measurements. So can we think about surveillance for health, for example, in the context of UHC, beyond disease surveillance? Because that's what we don't surveil health, we surveil disease. So how can we think differently about that? And lastly, really as a cut across point of focus on both preventive and curative or reactive dimensions of health and resilience. So I'll end there. Thank you.
Thank you, Professor Oni, for bringing and for detailing this big picture around all the issues that we have. I particularly liked also that you brought together what normally is thought about differently, non-communicable diseases and infectious diseases, that there are so many differences in dealing with it or in even to provoke them. I had the understanding that you really argue for a more healthy world overall, and this brings us certainly to the planetary health approach, right? So thank you for this. So we will head for the last speaker of our panel discussion. Dr. Christine Sørensen, who will bring in the next aspect about the people that I think much is about people. Christine Sørensen is a health literacy trailblazer, knowledge broker, and trusted advisor on health literacy and global health perspectives. She is the founder of the Global Health Literacy Academy. Her educational background is in medicine, public health, and global health diplomacy. She has served universities, international organizations, companies, and public authorities. Among others, the European Commission, the European Parliament, the European Centre of Disease Control, Council of Europe, the World Health Organization, and McKinsey. Christine Sørensen received the European Health Award 2012 and the International Health Literacy Award in 2017. The other, the HLA Global Health Literacy Award in 2018. She is honorary professor of Ishu University in Kaohsiung in Taiwan, and she is currently president of the International Health Literacy Association, executive chair of Health Literacy Europe, and chair of the Danish Health Literacy Network. She is advisory board member positions in various projects and organizations worldwide, such as Bridge for Health, European Health Future Forum, HELICAP, and editorial member for the journals Health Literacy Research and Practice. Christine, please go ahead. Thank you.
Thank you so much for this nice introduction, and to all my colleagues here for really setting the scene for, I think, a reorientation of health in the future. This is so exciting. I'm learning so much, but I also see that we are definitely thinking along the same lines. And my talk today really is about reorientation of systems based on health literacy. The World Health Organization's 3 billion goal calls for a reorientation on how we view health and how we organize our societal efforts to maintain and promote health. The 3 billion goal includes 1 billion more people to benefit from universal health coverage, and 1 billion more people protected from health emergencies, and 1 billion more people enjoying better health and well-being. And then I'm wondering, how do we do this when we know from our health literacy research that 2 in 3 don't really get the health information that we try to provide to them. They cannot find it, they cannot understand the information we provide, they don't know if it's relevant for them, and they don't know how to apply it in everyday life. So for me, we have a really neglected public health challenge that we need to tackle and to manage. And this is research is from Europe, so where we do think we have really good educational systems, good welfare societies, good healthcare systems, and still we fail. We don't match the needs of the people living their everyday lives. And then we still try to build universal health coverage, but how will we eventually get there? So I think we need to, if we want to get there, to invest in health literacy of the individuals, but also in the way we design our systems. We need to include health as a subject, for example, in education, in primary schools, even maybe in kindergarten. And when we have our systems approach, we really need to incorporate people-centered approaches and co-design strategies, and to a much wider degree than what we see now. I'm also calling for a reframing of health as an asset, not just like a burden of disease, but really as an asset, as a resource, as a capacity, where we move away from healthcare and fixing everything and fix and repair, instead of we should really focus on nurturing people's health, grounded in health promotion, and keep people healthy, not only just prioritizing how to cure their illnesses. And in this way, I really echo what my colleagues here said earlier, that we should change from a silo model to what I call a stream model, where people benefit simultaneously from health promotion, disease prevention, and health care, and health protection, health security, not jumping by one to the other. So when you are a patient in hospital, they will only focus on curing the disease, but they forget to to give you proper food or get the exercise that you need. So how can we create a system where we actually embrace health promotion, prevention, care, and protection at the same time? And then universal health coverage entails that we're aware of our rights and obligations as citizens, but this really requires that we know our rights and obligations. And this is where health education and health literacy come into place. How can we do this? For example, by securing better education, but also better education of health staff and staff in all these other sectors that my colleagues have mentioned. So transport, urban health cities, other areas where health is really executed. So where we live, where we love, where we work, where we shop. And we have seen now in the recent years a rise in social mobilization and bottom-up driven search for making the wrong policies of governments right, because really access to health is a human right. And with the increased digitization of health, we see that health has actually been democratized now, and knowledge is being democratized, which makes good health more accessible for citizens. So we do see groups who are actually now craving and calling for their rights. And this again takes a better governance to really shape those rights and entitlements. So we need a place where it's not only about living and surviving, but also thriving. And the prevailing pandemic has really shown us some gaps and cracks. And while we're waiting for a biological vaccine, we could think about investing in health literacy as a social vaccine, because this is crucial in the fight against the virus. And we have seen going to Asia that countries with a common memory on the SARS, they know how detrimental an epidemic can be. And many countries actually invested in their security systems and were much more prepared now for this emergency. And they also not only invested in masks, but also in health literacy in order to act timely and appropriately. So we can learn very much from them to raise our levels in the future. Lastly, health literacy saves money, time, and cost. It generates health empowerment and capacity for individuals and societies to take responsibility for improving health for all. It's a political choice, but it is also, for me, a human calling, a human imperative, and we need to respond adequately to this call and this problem. Thank you.
Thank you very much, Dr. Sørensen, for reminding us the power of people in the whole picture. And well, I mean, I was very amazed by your presentations all over, but I'm a little bit overwhelmed. You said, of course, we have to bring up all the silos, we have to break them up. We saw all the complexity around health on every level. We saw a lot of initiatives that we have to include, and we have to bring it up onto the very basic sector to primary care. So I'm wondering, we just also saw the long-term engagement, the need of long-term engagement in prevention and so on. So it seems really a huge, huge endeavor that we have in mind. And how can we make this happen in this world? So this is maybe the first question, and I will try to open the discussion by that. Do you think that the digital transformation, which we all will be experiencing, will this help us in all this endeavor, or will this more or less be a threat of it? So I'm just looking at my speakers, if someone of you would be ready to answer this question. And then please, one call to the audience, please place your questions into the questions area beneath the screen, please, so that we can hear what you want to contribute to the discussion. So is there anybody who wants to start and argue around the digital transformation, how it comes into the picture about health in all policies, about connecting all these different aspects which are so important around health?
Bernadette, if I may, I think that technology is very useful, but technology does not replace governance. It doesn't replace political will. It doesn't engage. It doesn't replace engaging with people and communities. So yes, I think going digital has a value, but it is not a magic wand that suddenly systems will be strong and universal health coverage will be a reality.
Yeah,
Thank you.
if I may add, I think COVID has shown that the digital health can be leveraged for a number of innovative ways of communities accessing care. Kenya, for example, has been able to establish a digital platform through which they are able to be in touch with pregnant women and those who are not able to access services because of various lockdown measures are continuously in touch with the service provider, the health providers, and they are able to determine if for whatever they are having a particular problem, they need to go to a health provider or not, thereby reducing the number of people physically in a overstretched health center and yet be able to target their presence in a health facility at a time when they need. So it goes back to what Christine talked about. There is a need for education in the community and also in the providers on how to leverage newer technology and digital technology to access services when people need to, and thereby do it in a manner where it is safe and beneficial to them. Maybe they can increase the number of contacts through these provisions without really physically being connected. So there is an opportunity to use it, but it needs to be done very carefully, as Dr. Mary Peel mentioned.
Thank you very much, Dr. Balaji. There is an endorsement for the statement of Dr. Keeney in the questions area. There is Sonia Monsalves saying, I agree with Dr. Keeney, digitalization will improve moving faster, but will not replace the analysis and the use of data by stakeholders, particularly health providers. So Professor Oni is lifting her hand. Please go ahead.
Yes, I think I agree with the comments that have been made so far. I think the other thing I would add that has been made very evident again by the pandemic is the inequitable access to digital technologies and to the internet. And so in as much as, I mean, it's absolutely true, digitalization won't solve everything, but also our approaches to equity, if we're thinking about implementing this kind of intersectoral approach, we have to be thinking about access to data and access to internet actually as critical for health. I have an image that I didn't show today when I talk about that connection between the interaction between human health and the environment and how that plays out in terms of transmission. And I talk about transmission in the context of transmission of disease, but also transmission of ideas and transmission of communication. And actually, if we think about it in that context, you know, we can't have equitable access to care without equitable access to information. And we see that in the context of COVID and how, you know, you see really laid bare where there isn't as much access, both in terms of understanding what's happening, but also your ability to mitigate and to take to follow the instructions in terms of sheltering in place, etc. All of those things are influenced by your ability to connect digitally. So I think just to highlight that inequity globally. And so in the context of intersectoral governance for health, I would say, you know, telecommunications, they are health they're health actors. So we ask, oh, in what roles can that sector play in reducing health inequity?
Thank you so much. Mujahid.
Yes, so I was just to add to what Dr. Oni said, I was thinking along the same lines actually, because there will be a lot of inequities which may not be realized today, but they may be realized 20 years down the line. And I'm thinking about health literacy and education. Look at low income and middle income countries where more than half the population doesn't even have good access to the internet. How will children study when you do not study online, when you don't have basic internet services? And there's going to be a huge divide that we will observe probably 10 years or 15 years down the line in terms of just health knowledge, or, whether it's economic outcomes, health outcomes, education outcomes. And one of the reasons goes back to what was mentioned earlier, that we work with political myopia here. Politicians that make decisions today are not going to make decisions 20 years down the line, or will not even be held accountable for these decisions. So I think that's a strong problem that we face today. So of course, digitalization is important, but it's not a magic wand, and I would agree with that statement.
Thank you. Christina, you
Yeah.
raised your hand as well.
I think we have to be careful not to be too naive. We saw that there are commercial determinants, commercial stakeholders that have access to data which is far beyond what we have as governmental stakeholders and health system stakeholders. So I learned, from this television series or documentary about Cambridge Analytics that they had 8,000 data entries on each user on social media, on Facebook, and I have my questionnaire on health literacy, which is quite comprehensive, with about 47 items on health literacy, and people complain that it's too comprehensive. But what can I get out of my 47 items when they have 8,000 or even more? So no wonder that they can tailor their information to, and create fake news that are just tailored to people's interest and not necessarily needs. So my question here would be, how can we as governmental stakeholders, healthcare system stakeholders, overcome this gap of information, that there are other people in society that have much more information and with bad, intentions might manipulate or trick human colleagues to do choices we would not necessarily see as the most timely and appropriate choices. So we should not be naive.
Mm-hmm. Thank you, Christina. I'm looking at, we have a couple of questions now in the questions room from our audience. And just we'll start with the first one from Sandy Ram. We have seen in Dr. Shaik's slides that some countries that have high universal health coverage levels are also known to have a lot of inequality in terms of healthcare access. How can governance support to decrease inequality in access to healthcare, and mainly primary healthcare? Mujahid, would you like to answer this?
Yes, thank you very much for the question. I think what we often think about universal health coverage, when we think about it, we think about access, and then we see inequities or inequalities in health outcomes. We have to remember and understand that access does not mean utilization. You can provide access, but that doesn't mean that the population will be able to utilize the services. There are several other reasons why, despite having access, the population might still not utilize healthcare services, and that itself leads to a lot of inequalities. So, for instance, one of the things that the WHO recommends as a goal of the health system is health system responsiveness. So, treating, for instance, patients with respect and dignity, client orientation, confidentiality, prompt services, and access to quality services. These are all sort of, in a way, non-medical dimensions of health, and these are often overlooked in many countries. In one of my papers, we look at how the caste system in India is responsible for leading to this inequity in utilization, simply because doctors and nurses do not speak properly with patients. Patients hesitate in even using those services despite having access to those services. So we need to put in mechanisms, governance mechanisms in place that target responsiveness of health systems. We need to hold providers accountable for the non-medical determinants, which actually lead to utilization. So I think that's very important.
Yes, thank you, Mujahid. It's an interesting point to look at this in that way. We have another question from, sorry, did I? No?
Yeah, I just wanted to add that part of governance also includes being able to look at indicators and information in a more disaggregated way by provinces, by districts, by different subpopulations, the wealth quintiles, by gender, and so on, and try and identify the the communities and the population groups, as well as geographic entities where there is inequities, and then proactively look at the barriers and bottlenecks that can be overcome to be able to access, to be able to provide universal health coverage. So governance is about looking not at national averages, but also looking at disaggregated data. And that is where, again, having people being a part of the governance system, public accountability systems, also brings in a fair amount of solutions. Over.
Thank you very much. We have a question from David Hipgrave saying, in many countries, upwards to 60% of THE is out of pocket. Many have voted with their feet away from public facilities they view as unsafe. How does the panel see the future of effective and affordable public-private partnership as a foundation for universal health coverage? So who wants to answer this question?
I may start if you wish.
Yes, thank you.
I think this is again, and Mujahid said so. This is a question of governance, and when health systems are unsafe, it's because they are left to be under-resourced, because we leave a situation of corruption. And this generates anxiety and fear, actually, of wrongdoing in health systems. And so therefore, again, I think restoring a proper governance, giving a voice to citizens so that they can say what they want from health systems, it will be critical to move forward on this. Over.
Thank you, Marie-Paul. Mujahid, you want to?
Yeah, I'd just like to quickly add to that. Thank you. So I agree with Christina. In fact, I think I recently heard somewhere, or it just came off to me, that responsibility without resources is like poetry, or it's basically fiction. You know, you can assign responsibility to all the structures and the people involved, but without giving them adequate resources, you can't really achieve much. Or going back to, you know, the case of public-private partnerships, for instance, I think when we look at the SDGs, I personally believe that we will not be able to achieve those without getting the private sector on board with us, without reaching an agreement with the private sector, or somehow collaborating with the private sector. I think that is so essential to achieving SDGs, because that's where a lot of jobs are generated. If we're talking about, you know, having decent jobs for people, if we're talking about having safe water, having safe sanitation, if we're talking about, you know, better food and so on. So I think engaging with the private sector is absolutely essential. The governance question then is of regulation. How do we regulate what we are doing with the private sector? I think that's where the governance aspect of it comes into play.
Professor Uni.
I want to make a tangential point to that, which is important, because the question was talked about public voting with their feet. And what I heard from that is the importance of the demand side of things, right? And, you know, we spoke earlier about, you know, politics being very short term and not thinking long term. And I do think that, picking up on Professor Sorensen's point earlier about health literacy, we have an opportunity, excuse me, that timing. Okay, sorry about that. We do have an opportunity when we think about health literacy, and perhaps to some extent, we also are guilty of focusing on the immediate when we talk about health literacy. So, I mean, should we be asking, in addition to thinking about, talking about the role that the public play in kind of voting with their feet, can we actually increase the demand for healthy environments? Can we actually increase the demand for intersectoral accountability for health? And can we tailor when we talk about health literacy, can we tailor our health literacy not just to the needs of today, but actually to create a more health literate population that's saying, you know, I can see how the air I'm breathing now is impacting my child's health of tomorrow, and I actually demand health from the sector that is driving that health pollution, so that if we don't have a political long-term thinking, we're actually driving increased demand for long-term thinking about place. And I think that's something that has to be deliberate, and perhaps we don't sufficiently focus on thinking about strategies to increase the demand side of things for healthy places and healthy environments as a critical part of one's health and the health of one's community.
Thank you. There might be another question for you from the audience. Sainat Farugi is asking, is resilience a multi-sectoral concept? Is it achievable with cross-sectoral planning? Do you want to answer on this one, Tulula?
Yes and yes. I mean, the issue about resilience is that you're right. It's absolutely something. It shows that, especially if we're thinking about it from a proactive perspective, and we're thinking about what are the factors that make us more resilient to today's system, and what are the factors that are forcing us to need to be more resilient, if you see what I mean. Because in a sense, we want to be driving both increased resilience today, but also reducing the need to be so resilient, if you see what I mean. In as much as when we talk about healthcare, we're both talking about increasing or reducing unmet need for healthcare, but we're also talking about reducing the need for healthcare altogether, because health cannot just be about healthcare need. We have to be driving, we're actually saying there's some inevitabilities, sure, but there's quite a lot of need that is preventable. And so how do we actually reduce that need, and not just focusing on reducing the unmet healthcare need? So I think absolutely it has to be multisectoral. And if we're thinking multisectorally, I hope then we're thinking in that upstream way. And planning is an important side of things, because when we're talking about governance, it really is not just about what everyone doing what they're doing normally anyway and bringing it together in the end, but actually starting from an outcomes basis to say, I think Professor Sorensen mentioned a thriving society. Everybody talks about, you know, any city, town, country talks about a thriving population. If that is the goal, then let's talk about what the indicators of that would be. And let's talk about how every single sector is contributing to that indicator. Because if we're not doing that, we're not, you know, as I mentioned, health doesn't trickle down from good intentions. We will have a situation where the healthcare sector is doing their best, maybe one or two others, but you have other sectors that are actively undermining health. So we have to think in this kind of cross-sectoral approach to really tackle resilience, particularly proactively.
Thank you very much, Professor Oni. I think we have to come to an end. The point is that we have still a couple of questions open, and I'm just looking to the support team right now if we have the possibility that we can tell people to connect right away to the speakers and send them an email with the question they still have openly. I think this should be possible, right? Maybe you can give an answer on this one. No, support is silent, but this is what I would like to recommend for the people who have still are on their open questions. Please go ahead and send an email to the speakers, and they can answer you right away. I would like to thank the whole group very, very much for really these amazing inputs. It was really, really very interesting. Overwhelming sometimes, because I mean the challenge is really, really huge. It is indeed. But I think if we can put element by element, we go there step by step, and this is the hope that we have. I wish you every good Sunday around the world, wherever you are. And yes, stay healthy. and take care. Bye, and thank you very much.
Thank you, Dr. Bernadette.
Thanks, everyone.
Thank you.